Hello dear students, today I am going to speak to you on abnormal shapes and sizes of head. The causes of abnormal shape or size of head depends on the content of the brain, such as the brain matter, CSF, or any other extra cerebral matter such as blood or maybe a tumor. Or it could be related to the development of the skeleton, which is the skull. It could be familial, which is a term which we use when there is no other related abnormality but just the size and the shape of the skull. Genetic and chromosomal abnormalities also cause difference in the head and head shape and size. Here there is usually impaired intelligence as well. First, let's look at the causes of a large head. A large head is also known as macrocephaly. Macrocephaly or large head is defined as a head circumference more than 2 standard deviations from the mean. The first cause could be increase in the volume of brain matter, which is again known as megalencephaly, where the brain matter is increased. It could be due to enlarged or dilated ventricles when we call it hydrocephalus. It could be also due to accumulation of substances outside the brain, as I mentioned before, chronic subdural effusion or a subdural hemorrhage. It could be an intracranial tumor causing a large head. So if it is a tumor, it should be a slow growing tumor that it affects the growth of the skull. Because if it is an acute tumor, then the symptoms will be more dramatic. Then there is a thing called vein of Galen aneurysmal malformation, where arterioles and small arteries, capillaries open into the vein of Galen, causing a high pressure in the venous system, causing edema of the brain, cerebral edema, increased CSF and hydrocephalus, and because of this abnormal connection, the child can be in heart failure, a high output heart failure, and developmental delay, failure to thrive, and such things. First, let's look at megalencephaly. As I mentioned before, it is due to the increased growth of cerebral matter. It could be benign, as associated with no abnormality but just some increase in the brain matter. Or it is called as anatomical, where there is an abnormal proliferation and migration of neurons. This condition is seen in achondroplasia, Soto syndrome, neurofibromatosis 1, Beckwith-Wiedemann syndrome, and so on. And then a metabolic cause can be there, such as organic acidemias, leukodystrophies, or lysosomal storage disease. In these conditions, abnormal substances may get accumulated within the brain cells or within the interstitial tissue, or it can cause a sort of bleeding in the subarachnoid space, causing a large head. So there are various mechanisms which cause large head in metabolic disorders. Hydrocephalus. Hydrocephalus, as you know, is the dilatation of the ventricles. It can be due to a block or an impedance in the CSF flow, which is known as obstructive hydrocephalus or non-communicating hydrocephalus, or it can be due to accumulation of CSF without obstruction in the flow, which is known as non-obstructive or communicating hydrocephalus. Hydrocephalus can be congenital or acquired. So first, let's look at the ventricular system. Here's a nice 3D image which I got from the internet. You can see the two lateral ventricles, right? Their posterior horn and the inferior horn and the body. And then you can see the third ventricle connected by two foramina of Monroe, and then the third ventricle opening into the fourth ventricle, which is sort of a diamond shaped thing, through the aqueduct of Sylvius. And of course the fourth ventricle will continue downwards as the central canal of the spinal cord. So again a static picture of the same detail. So the lateral ventricles, intraventricular foramina, two of them, then the third ventricle, the cerebral aqueduct and the fourth ventricle. Right, so let's look at some causes of congenital obstructive hydrocephalus. So as I mentioned earlier, it is due to obstruction in the pathway of the flow of CSF, and the congenital causes are aqueduct stenosis, Dandy Walker malformation, Chiari malformation type 2, intraventricular hemorrhage in a preterm infant, posterior fossa neoplasm. So the congenital causes, acquired causes could be posterior fossa neoplasm blocking the flow of CSF, and then the post-inflammatory blocking the aqueduct of Sylvius or foramina of Luschka and Magendie, which conducts the CSF from within the ventricular system into the subarachnoid space. So when we take aqueduct stenosis, it is a fairly common congenital malformation, and as the name implies, there is stenosis or narrowing of the third the aqueduct, the cerebral aqueduct. So here is a normal brain, right? So here you can see the lateral ventricles, and you can see the third ventricle, or barely see the third ventricle, and you can see the fourth ventricle. But here in this picture you can see a dilated lateral ventricle, a large third ventricle, and the fourth ventricle is small, and the block is here. And because the enlargement is in the front part of the head shape sort of a box shape or a round shape. Right? So that is the abnormal thing. And so you can see the hydrocephalus here in the aqueduct stenosis. So the stenosis is here, and the shape of the skull is seen. Right. Let's look at Dandy Walker malformation. So in Dandy Walker malformation, there is a large cyst-like space in the posterior fossa. So the fourth ventricle is enlarged, and the abnormality is due to the vermis of the cerebellum not being properly formed. So there is hypoplasia of the vermis of the cerebellum, and therefore the fourth ventricles are dilated, right? And because the fourth ventricle is dilated, in the MRI scan you can see the lateral ventricle, the third ventricle, and the fourth ventricle is quite enlarged, and the CT also shows the same thing here. And you can see the shape of the child's skull. It is elongated anteroposteriorly because it is posterior, prominent posterior fossa. So in this baby here also you can see this prominence. So Arnold-Chiari malformation, which is also known as Chiari type 2. So in Chiari malformation there are 4 types, and the second type is known as Arnold-Chiari malformation, the name of the researchers. So Chiari type 2 Arnold-Chiari malformation is basically associated with the meningomyelocele, right? So the meningomyelocele is caused by is associated with folic acid deficiency or deficiency in the enzyme tetrahydrofolate reductase. So we advise mothers in the preconceptional state to take additional folic acid to reduce the incidence of this type of malformation. Now let's see what happens here. So here there's an opening here, and there's free flow of CSF all throughout, right? And then what happens, that we can't leave the child here like this, so we will close it. So when it is closed, there can be, now because of this overflow, it is believed that the CSF production is also more. So the moment you close it, the CSF accumulates, causing a hydrocephalus. That is one theory. Another theory is that due to this leakage of CSF, the cerebellar tonsils herniate and cause an obstruction here, causing hydrocephalus. So either way, the hydrocephalus may be seen immediately after birth or after closure. So it could be the cause or the effect or association, right? So because of this lumbar spinal cord involvement, you can see this girl, she is weak in her limbs, so she uses this walker and she walks around, right? So if you are going to, if I have to talk about meningomyelocele, it's an entirely different topic. So you should know how to identify the level of weakness and the involvement of various segments and the bladder and bowel control and those things, right? Okay. Right. Non-obstructive hydrocephalus. There is failure of reabsorption of CSF due to damage in the arachnoid villi. Right. So when there is a subarachnoid hemorrhage or meningitis or tuberculous meningitis, then there can be disturbance in the reabsorption. Or if there's a choroid plexus tumor, there can be excess production causing a hydrocephalus, right? So the inflammatory conditions like meningitis, usually we see both type of hydrocephalus can be seen, or it can cause both type of hydrocephalus, right? So here are some common features of hydrocephalus. Of course, the large head, that's why we are discussing it here. Dilated scalp veins may be seen. Suture diastasis, which is the separation of sutures. So if you feel over the head of the baby, you can feel a ridge or a space between the suture, the bones, right? Transillumination is a sign which is seen when there is excessive or markedly enlarged ventricles. The setting sun sign is the downward gaze of the baby's eyes. That is due to an upward gaze palsy, and it is believed to be due to the pressure in the oculomotor nerve nuclei in the flow of the third ventricle. Then often we get a stridor in these babies, and that is believed to be due to the compression of the vagus nerve or its nuclei in the flow of the fourth ventricle. We know the vagus nerve has a long nucleus which is situated in the floor of the fourth ventricle. So when there is pressure there, you can get a vocal cord paralysis causing stridor. Then spasticity of limbs are also seen. This is believed to be due to the stretching of the internal capsule. And this is a picture of transillumination. It is possible in extensive hydrocephalus or hydranencephaly. What is hydranencephaly? Hydranencephaly is a condition where there is hardly any brain, just the ventricles or sacs filled with water. So it has a massive CVA and the brain matter is totally lost, you may get a hydranencephaly, right? These babies may look normal at birth because they have their spinal cord reflexes, sucking reflexes, everything intact, but they hardly show any development after that, right? And then a large porencephalic cyst also can show a transillumination of head. Porencephalic cyst is again a massive hemorrhage in a part of the brain, causing it to necrose and filled with water or liquid, right? So here hydranencephaly, brain matter replaced with fluid filled sac due to massive ischemic necrosis, right? Then we come across a thing called benign familial large head. As I told you before, this is usually due to they are usually normal, right? It is common in boys, and sometimes it is conducted or inherited as an autosomal dominant trait, and one of the parent may have a large head. They may have a larger head circumference at birth, and suture diastasis may be seen. Some studies say there may be slight suture diastasis in the early age, and lateral ventricular diameter may be slightly higher, or usually it is normal. And some studies have shown increased IQ because of this large benign familial large head. And then there's another condition where we may see rapid growth in the head circumference in baby, like 6 months, 7 months. Otherwise they are okay, but these babies usually around 2 years the head circumference normalizes, right? So they won't go on, they just grow fast and then they attain the normal size. So this is a flow chart of some sort. So head circumference more than 2 standard deviations is a large head or macrocephaly, and here in this author says that if no diagnosis and if brain MRI is normally it's macrocephaly, right? So he is mainly concentrating on the megalencephaly part. If there is no neurological impairment, we can call it as benign megalencephaly. If there is neurological impairment, we have to do the laboratory test, or with laboratory test or without laboratory. So without laboratory abnormalities, it's called anatomical megalencephaly, it's known as, and these are the achondroplasia and other causes which we discussed or mentioned, and metabolic, the organic aciduria, lipodystrophies, and so on. Right? Just know it, that's enough. Now let's look at the causes of a small head, which is microcephaly, where the occipital frontal circumference is less than -2 standard deviations or less than the third centile. This is usually due to arrested brain development, like intrauterine infections, toxoplasmosis, rubella, herpes, syphilis, cytomegalovirus, HIV, and of course Zika virus, which drew some attention in the recent years. Then cerebrovascular accidents, hypoxic damages, neonatal meningitis, encephalitis, degenerative disorders, metabolic disorders. Now we saw metabolic disorders can cause large head. Similarly, metabolic disorders like phenylketonuria can cause small heads, right? Chromosomal and genetic abnormalities, right? We saw a few chromosomal abnormalities like neurofibromatosis, certain disease causing a large head, and here like Turner syndrome, Brown syndrome, Edwards, and so on, they will have a small head. Right? Again, familial conditions are there when there is no other abnormalities associated. Autosomal recessive, autosomal dominant, X-linked, and all. And here, however, they have found that there may be mild mental retardation. Right. Now let's look at abnormal shapes of skull. So shapes of skull may be due to the premature fusion of certain sutures, which is known as the craniosynostosis, and causes that are not really related to craniosynostosis, right? So craniosynostosis means premature fusion of certain sutures in the skull. So they may be found as a part of a syndrome like Appert, Pfeiffer, Cruzon, Carpenter, and so on. And some children may have craniosynostosis without actually falling into any syndromic phenomenon. Causes not related to craniosynostosis causing abnormal shapes are deformation, plagiocephaly, which we will talk about a little later, osteopenia of prematurity, where the skull is soft due to rickets of prematurity, and the shape changes due to sleeping on the same side. Then rickets, then again familial. So some families, they have different shape of head, which is normal, otherwise normal, and of course genetic and chromosomal abnormalities will come into play. So these are the names of the sutures which cause abnormalities in the shape. Scaphocephaly due to premature fusion of sagittal, brachiocephaly due to coronal, trigonocephaly due to metopic, plagiocephaly asymmetric fusion of coronal or lambdoid suture, and taricephaly due to fusion of sagittal and coronal. So here there's a picture here. So this is the metopic suture, and if it fuses early, the brain cannot grow lateral wise, so it has to grow, the skull has to grow anteroposteriorly. So the skull takes a triangular shape, right? Similarly, you can work out each and every suture and how it can distort the shape of the skull. Right, so again this is the metopic suture which has fused and causing a triangular shape or trigonocephaly. And scaphocephaly is elongation, also known as dolichocephaly. You can work it out. The brain cannot, the skull cannot grow lateral wise, so therefore it is growing anteroposteriorly. So it must be the coronal suture. So the coronal suture, if it is fused, the sagittal suture. If the sagittal suture is fused, the brain cannot grow laterally, so it has to grow anteroposteriorly. Plagiocephaly, you can see the plagio means a sort of oblique thing. So because of one of the sutures here has fused in this side, the head is growing on to the right side. So brachycephaly is a flattening of the skull, which is seen in Down syndrome. So this is Apert syndrome and Cruzon. Both of them have craniosynostosis of various sutures, and the characteristic feature in Apert syndrome is a sort of a sunken look here, and polydactyly. Here is the orbital proptosis is a common feature, and in these children, Cruzon syndrome can be affected with breathing difficulty. Right. So what are the complications? So there can be developmental delay because the brain can't grow freely. There can be cognitive impairment. There can be blindness. Eye movements can have problem. They can get seizures. If it's a severe case, then death can occur due to compression of the brain or inability to breathe and so on. And if it is not very severe, even it can cause poor self-esteem in the child and isolation because they look different. So management wise, reconstructive surgery is possible these days with multiple expertise, and of course psychological support to the family, for the child and the family, and rehabilitation. So deformation plagiocephaly is not a very rare phenomenon. It happens in normal children where there is asymmetry and flattening of skull due to continuous external pressure. So sometimes it is due to intrauterine abnormal shape of the uterus oligohydramnios, where there is pressure on one side, or in the postnatally when you keep the child sleeping on the same side, it can happen, especially with preterm babies. And in the West, there's a phenomenon called sudden infant death syndrome, where they say it is due to the sleeping position. If the baby sleep on prone position, they are more prone to get SIDS. So they are now promoting, the West, it's promoted the baby should sleep on the back. So when the baby sleeps always on the back, then the head also becomes sort of a flat abnormal shape, because the head is not given the liberty to roll around and get its own shape. There's no special treatment needed, but it improves with time. But still, for all, if you go to the internet, you can see they advise various sorts of helmets and pressure, right? And even our grandmothers sometimes advise that you should massage the head to get a nice shape. So actually, if you leave it alone, it will assume a good shape of its own. So this is the example. So this is a positional plagiocephaly or deformation plagiocephaly, where there is contralateral occipital bossing and ear displacement, and this is the due to the plane of sleeping. But here this is a parietal bossing. You can see the ear, right? So here ear has not been pushed to the, here the parietal bossing due to fusion of this lambdoid suture right side. So therefore this part is bossing, and you can say this anteroposterior diameter is more and this is less. Here it is almost the same, it's just got a rhomboid shape, right? And this has a trapezoid shape. Thank you. Good luck. Enjoy your pediatrics.